Pediatric CT surgery is going to be all about identification of the murmur. There are a lot you could study, but there are only a few that actually come up. So we're going to go over left to right shunts and the ones you need to know, then right to left shunts and only the ones you need to know. Before we get going, if you talk about adult murmurs, what you're looking for is innocent versus pathologic. And when you do this in adults, it's usually a grade 3 or higher on a systolic murmur, or any diastolic murmur needs investigation. And to investigate, you get an echo. For kids, it's basically the same thing. To diagnose, get an echo. Chest X-ray, EKGs might give you clues, but it's the echo that makes the diagnosis. The trouble with kids is that they might have such a bad defect, you may not be able to hear it at all. So that concept of innocent murmur is lost, especially when the murmur is present in the hospital after they're born in the first couple of days. The reason for that is murmurs are created by flow over area. So if you have a really big defect, you might not hear anything. Let's start off with left to right and then the individual diseases. A left to right shunt is caused by a hole. That is, there's some random connection between the left and right. The right heart is weak and floppy because the pulmonary artery resistance is low. The left ventricle is big and beefy because systemic vasculature has high resistance. If you put a hole, the blood is going to take the path of least resistance from the left side, really strong, through the low resistance system, which means you're going to have increased blood flow through the pulmonary artery. And you're going to put already oxygenated blood from the left ventricle back into the pulmonary vasculature. The blood is going to be oxygenated. The first consequence of this is that all the left to right shunts are non-cyanotic. That is, baby is not blue when they are born. The problem with increasing pulmonary arterial flow is that you're going to increase pulmonary arterial pressures. And this is going to increase the pulmonary arterial resistance. I know you're starting to go, pressure and resistance, what is he talking about? The idea is if you keep slamming this high pressure left ventricle blood into a low pressure system, it's going to get bigger, beefier itself. It's going to increase its resistance. And the right heart, which is used to seeing no pulmonary hypertension, all of a sudden sees pulmonary hypertension. And so the right heart is going to hypertrophy. And the right ventricle is going to get big and beefy, just like you working out at the gym. And eventually, the right heart is going to become stronger than the left. And that's when you get Eisenmenger syndrome. Eisenmenger is a reversal of the shunt, which goes right to left, becoming cyanotic. That happens later on in life, not in pediatrics. There are 3 diseases you have to know. That is the atrial septal defect, the ventricular septal defect, and the patent ductus arteriosus. Notice that there's a D in each of these. Let's start with a model of the 2-chamber heart. You've got the atrium with a valve and a ventricle. You've got another atrium with a valve and a ventricle. And then you've got your aorta, and behind it, a pulmonary artery. In an atrial septal defect, there is a hole between the 2 atria, such that normal blue deoxygenated blood goes from the right atrium to the right ventricle, from the right ventricle through the pulmonary valve, and then into the pulmonary artery. That's normal. Oxygenated blood returns to the left atrium and goes through the left ventricle, out through the aortic valve, into the aorta. But now there's a hole that allows blood to go from the left atrium back into the right ventricle, adding extra blood to the pulmonary artery. The atrial septal defect is caused by a hole between the left atrium to the right atrium. And there's some sort of primum and secundum defects that you do not have to recall. I just want you to identify words that you saw on step 1 so that you see it again, you at least know what it is. Now this can be diagnosed at any age, and it is the most common congenital defect after age 1, and that's because ventricular septal defect either gets repaired or they die. The thing that's going to tip you off for the test is a fixed split S2. The fixed split S2 is the thing that tells you it's an atrial septal defect. As we've discussed, the diagnosis is made with an echocardiogram, and the treatment is going to be closing the hole. Because these holes are usually small and you don't want to crack the chest, this is usually done with a device. Make sure you're able to track the red oxygenated blood and the blue deoxygenated blood for all of these drawings. Now, if you got atrial septal defect, you can pretty much deduce what ventricular septal defect is going to be. Again, two-chambered heart, there's the atrium, there's the other atrium. Only now the hole is between the two ventricles. You still have your aorta and your pulmonary artery. And again, you're still going to have normal blood flow from the right atrium, right ventricle, pulmonic valve into the pulmonary artery, deoxygenated blood going into the lungs to get oxygenated. Normal. You're still going to have the normal oxygenated blood coming from the left atrium into the left ventricle through the aortic valve and into the aorta. Normal. But now you've got a defect in the walls of the ventricle which allow blood to go from the left ventricle into the right ventricle and back into the pulmonary artery. Very similar, just the holes in a different spot. The path here is that there's an opening, a hole, between the left ventricle and the right ventricle. This is associated with Down's syndrome. The patient is going to present at less than 1 year of age. In fact, this is the most common cardiac defect, less than 1 year. And the reason why that is because either they get it fixed or they die. Again, remember, a murmur is created by turbulent flow over area. So you might have a completely asymptomatic but very loud murmur. That's because the hole is small. Or you might have an inaudible murmur with failure to thrive and florid heart failure. The diagnosis is made with echocardiogram. And the treatment is dependent on how bad it is. If it's an asymptomatic loud murmur, which you're actually very worried about because you hear it, you're like, whoa. If it's asymptomatic, you can just wait up to 1 year. And if it goes away on its own, great. If it doesn't, you need to do surgery. If they've got florid CHF, it doesn't matter what the murmur sounds like, you need to surgically repair it. This is usually done with surgery, not an endovascular device. And the last one, patent ductus arteriosus, is going to be nothing to do with the atrium or the ventricles. So I'm just going to draw a little heart-shaped heart. It has everything to do with the aorta and the pulmonary artery. That is, in utero, we want to bypass the lungs, and so we have a connection between the aorta and the pulmonary artery. Once baby comes out, we want oxygenation to occur in the lungs, so that should close. Well, a patent ductus arteriosus is a connection between the aorta and the pulmonary artery, which persists. It's not supposed to, but it does. That is Oxygenated blood from the left ventricle goes into the aorta and down to the periphery, but it also travels across the patent ductus into the pulmonary artery, where it mixes with deoxygenated blood from the right side of the system. The patient is going to present with a murmur that is not present on day 0. And the murmur is going to be written out as a continuous machine-like murmur. Now, machine-like is too much of a buzz phrase, so they might actually give you multiphasic. If you hear multiphasic friction rub, you should think pericarditis. If you hear continuous multiphase murmur, think patent ductus. But this has to be in the newborn nursery because this thing is supposed to close in the first 24 hours. And if it doesn't, baby's going to notice. Diagnosis is going to be made in an echocardiogram. And the treatment is closure when you need it. That's what that means. Use indomethacin. Indomethacin to end the patent ductus. But you might want to keep that open. As we'll talk about in transposition, you need to give prostaglandins to maintain the patent ductus. Now, you're not going to do this for life, but in the first couple of days until you can get baby to surgery, you may need to do that. So in this first half of the lecture, we talked about left to right shunts. Blood goes into the pulmonary artery when it's not supposed to, and eventually it reverses to Eisenmingers. ASD is a hole in the left atrium to the right atrium, fixed split S2, device closure. Ventricular septal defect, most common congenital defect, up to 1 year, either asymptomatic but really loud murmur, or really sick kid, failure to thrive, CHF. Depending which one it is, you can wait, but eventually you'll need surgical repair if it doesn't fix itself by year 1. Patent ductus, continuous machine-like murmur. Indomethacin ends the PDA, and prostaglandins keep it open. Let's transition to talk about right to left shunts next. Let's start the second half of this lecture with the right to left shunts. Now, right to left shunts have to be more than just a simple hole. That would be left to right until Eisenmingers comes in. So in order to get blood from the right side of the heart to the left without just being a hole means some sort of catastrophic failure. And that catastrophic failure leads to not a lot of blood going to the lungs, which means the blood is not getting oxygenated before it goes to the periphery, which means baby's going to be cyanotic. And these present with blue babies right away. It is day 0. And this is not someone who's a little cyanotic, right? They are blue, and no matter how much oxygen you give them, they do not get better. So if you don't do anything about it in the first day, they die. These are the T diseases. Left to right were the D diseases. Right to left shunts are the T diseases. Now, there's only actually 2 you have to know. Some others you might have learned for step 1 to challenge your embryologic development knowledge. Truncus arteriosus, tricuspid atresia, total anomalous venous return. Cool names, you don't really see them in practice all that much. So the 2 I want you to know about are going to be transposition of the great vessels and tetralogy of Fallot. Transposition of the great vessels occur in moms who are already diabetes. They have diabetes, they are diabetics, and not in gestational. The reason for this is the heart develops at week 8. In order to be diagnosed with gestational diabetes, you have to have no diabetes and get it after week 20. By then, the heart is already developed. So the babies at risk for transposition are those with moms who are already diabetic when they conceive because at week 8, there's a failure to twist. If you ever wondered why the heart anatomy was so hard for step 1, it's because everything's three-dimensional and spun around itself. What's supposed to happen is the aorta gets connected to the left ventricle and the pulmonary artery to the right. But if the heart doesn't twist, that doesn't happen. So if that doesn't happen, you're going to have 2 independent systems. The first system, in blue because it is completely deoxygenated, is going to be a right atrium to right ventricle to aorta and back to vena cava, right atrium. A systemic system that never sees oxygen from the lungs. The other system is fully oxygenated. It is a left atrium to left ventricle through the pulmonary artery and back to the pulmonary vein. It never sees the periphery but stays constantly oxygenated. Let's see what this looks like. It'll be easier. The right atrium connects to the right ventricle, and the right ventricle connects to a blood vessel that comes back to the right atrium. This is the right atrium, right ventricle. If they fail to twist, this is the aorta with return to the vena cava. On the other side, we're going to have the atrium connected to a ventricle. That ventricle is going to be connected to an artery that then returns blood via vein back to the right atrium. Right atrium, right ventricle, pulmonary artery, pulmonary vein. The only reason why this neonate did not die in the womb is because mom was oxygenating its blood via the placenta. At that point, we had a patent ductus. And so to here, the patent ductus is required for survival. It is not sufficient to survive, but it is necessary. The patent ductus allows a connection between the oxygenated and deoxygenated blood, which allows you to get that kid to surgery. The patient is going to present, very obvious, blue baby, first day, dies if you do nothing. You don't really have time for the diagnosis, but if you're going to do a diagnostic step, it would be an echo. And the treatment is going to be surgery. But in order to get the baby to surgery, we need to ensure that the patent ductus stays open, so we use prostaglandins. Prostaglandins keep the patent ductus open, indomethacin ends it. Transposition, diabetic moms, blue baby, prostaglandins first. Tetralogy of Fallot is an endocardial cushion defect. And more so than a simple VSD, it is associated with Down syndrome. Now it is a tetraology, so there are 4 pieces to this. It all begins with a really large ventricular septal defect. And the opening for the aorta and the pulmonary artery are shared. Now the aorta is bigger and meaner, higher pressure. So it pushes the pulmonary artery out of the way of that shared space. That is the overriding aorta and the pulmonic stenosis. And because of that pulmonic stenosis, the right ventricle is going to have to keep up with the left, so you get right ventricular hypertrophy. Let's just keep an eye on what happens through the pathology of tetralogy. You've got the right atrium and the right ventricle, left atrium, left ventricle, but a very large ventricular septal defect. The left heart starts off big and beefy. Now you've got a common shared opening for the aorta and the pulmonary artery. The aorta is big and mean, and so it pushes aside the pulmonary artery. So most of that opening is aorta, and then a little bit of that opening is the pulmonary valve to the pulmonary artery. That's the stenosis. Overriding aorta just means aorta takes up most of the space. Pulmonic stenosis means the pulmonary artery doesn't. So deoxygenated blood comes in from the right atrium and through the right ventricle will leave through both the pulmonary artery and the peripheral vasculature, sending deoxygenated blood to the periphery. So what you'll see in your aorta is deoxygenated blood. But what little bit does go through the pulmonary artery, also deoxygenated. Therefore blue. Blood returning from the lungs through the left atrium goes into the left ventricle, and it does the same thing. It'll send most of its blood through the aorta, but also a little bit through the pulmonary artery. So you'll have a mixed picture in both the periphery and in the aorta. But as the right ventricle experiences this increased pressure from the aorta, it too is going to grow and become big and beefy. That is the right ventricular hypertrophy that accompanies tetralogy. You didn't catch all that? Go back, watch it again. It's actually not that hard, but you have to make sure you understand it all. The patients are going to present in one of two ways. Either it's a blue baby that dies at birth. It's generally not going to be that on the test. Or it will be a kid who's slightly older who has TET spells. A TET spell is pathognomonic for tetralogy. That is a kid who's blue who then pinks up when he squats. When you squat, you improve venous return. You give more blood to the right ventricle. RV is preload dependent, makes it work better. And you increase the systemic vascular resistance, making it more favorable to push blood through the pulmonary artery, which means that both the left and the right heart are pushing more deoxygenated blood through the pulmonary artery. That spells blue baby pinks up when he squats. You don't need to do this step. They might give you this information on your test, a chest x-ray that shows a boot-shaped heart. The diagnosis is made by an echo, since we're in cardiology, and the treatment is surgical. And we're going to close with one that is not a right to left or left to right shunt, that is coarctation. Coarctation of the aorta. There's nothing wrong with the atria or the ventricles. But the aorta, and it must be past the great vessels, has a stenosis that then opens up again distal to the problem spot. Now it must be a descending coarctation. If it were ascending or proximal to the great vessels, an arm wouldn't form or half a baby's head wouldn't be there. So it must be distal to the great vessels. The problem is that blood that goes from the left heart into the aorta has no problem getting to the upper extremities, but it does have problem getting to the lower. And eventually collaterals will develop, but the symptoms will still remain. Extra blood to the top, not enough blood to the bottom. So what you're going to see is hypertension in the upper extremities, but hypotension in the lower extremities. This may also manifest itself in the way of warm upper extremities, but cool lower extremities. You might see claudication. Now, claudication in an infant is not the same thing as someone who's a 65-year-old smoker with vascular disease. Same concept. Blood cannot get to the legs sufficiently. So a child may refuse to walk or cry when it tries because the legs are becoming ischemic. It's extra perfusion to the top, poor perfusion to the bottom that gives away coarctation. The same presentation you'd think of in an old person with peripheral vascular disease, only it's a young kid who refuses to walk. Diagnosis is going to be made with an echo. The angiogram is not done in kids. And a chest x-ray looking for rib notching is not going to be prudent in a young child. Those collaterals have not developed yet. The treatment is going to be surgical. Okay, so we talked about right to left shunts as catastrophic failures, no transposition, diabetes, echo, prostaglandins, and tetralogy, Down syndrome, TET spells, boot-shaped heart, surgery, coarctation. Sounds like peripheral vascular disease, only the child is 2. Get the echo, fix it with surgery. That's Peds CT. Become a better doctor. Subscribe now to get access to our premium content.